Well, hello and very good evening to all. I, Dr. Dhammadip Dabhade, on behalf of emcure Pharmaceuticals Limited, welcome you all on the occasion of acute MI workshop and e-webinar series, and this is the first session of this series on the topic thrombolysis in STEMI, when to and when not to. This is the scientific initiative by the emcure in association with the Association of Physicians of India, API, and in which we are expecting the learning, understanding, and discussion about the MI with this given topic. For that matter, we do have the experts with us today, and we will be having the dedicated talk on this particular topic. So it's my privilege and honor to introduce the chair of the program for this particular session, Professor Dr. Vijay Bangsa. Sir is the honorary consultant international cardiologist been affiliated with the Lilavati Hospital, Mumbai. Sir been the president-elect and chairman, Scientific Committee CSI 2022 and the president committee for CSI 2023. Sir been the honorary professor and HOD cardiology at the Grant Medical College and JJ Group of Hospital, Mumbai, and been instrumental in starting the IVUS or FFR in 2006 as a professor and head at JJ Hospital. And Sir has many awards and recognitions in his credit. Just to note few of them, like the A.V. Gandhi Award for Excellence in Cardiology in 2006, International Award for Excellence in Cardiology with gold medal by WCCPCI 2013. The special credit for Sir, the Foreign Minister of Kenya certified him as a goodwill ambassador between two countries in a letter to Foreign Minister of India. And Sir has published numerous book chapters, articles, and editorials in many national and international journals. So with those few words, once again, I'm thankful for Dr. Vijay Bangsar for here with us today to chair the session ahead. Then I would like to introduce our speaker, the expert speaker today, Dr. SUNIL THANVI sir, who is from the Ahmedabad, been the professor in HOD cardiology and the senior interventional cardiologist from Zydus Group of Hospitals of Ahmedabad. Few words about him. Dr. Nathuvai Patel Gold Medal been awarded to him in cardiology by the Gujarat University. Been awarded with the UN Mehta Gold Medal of Cardiology by BJMC Alumni Association. Been awarded with the Glory of Gujarat Award in 2015, and over 50 papers been published in his credit at the various national and international journals. The first original paper presentation from him ever at the Pediatric Interventional Cardiology Symposium at Chicago in 2004 is there, and been awarded with the best paper at the APG Con Rajkot conference, and been awarded with the best moderated post abstract at the TAP 2016 at the Seoul, South Korea. So with those few words, I would like to mention few words about the course director, who is actually the course director for our whole webinar series, Dr. AGAM Ora, who is the honorary General Secretary of the Association of Physicians of India, and who will be sharing with us in the beginning of this program with his remarks. And this is how the agenda for today's session will be, that after my introductory remarks, we will be having the remarks for this series by Dr. Agam Ora, and then the context setting with the few remarks regarding this topic today from our today's chair of the program, and we'll be going for the presentation part, and then we will be having the discussion round. So with that note, I would like to stop here, and I request my colleague to just share the message given by the Honorary Secretary, Dr. Agamora of API, with the audience, to share the message by Dr. Agamora.
Good evening, everybody. I'm Dr. AGAM, your Secretary of Association of Physicians of India, one of the most vibrant, one of the most academic, one of the most happening associations of physicians across the country. I'm very happy to present to you today the first program in the series on acute myocardial infarction. We've had one program on heart failure series, and this is the first program in myocardial infarction series. Today, we are going to be talking on thrombolysis in STEMI, when to, when not to. And I'm very happy to present the excellent faculty that we have today. We have Dr. Vijay here, we have SUNIL THANVI here, and there are going to be question answers at the end of it. And I urge all of you to make the best use of it. Use the chat box which is provided in front of your screen, and I promise to solve all your queries that you have on this particular topic. I was talking to Team emcure, I think it's about 4 months ago, and looking at the need for our delegates, we proposed a program on heart failure and myocardial infarction. They're very happy to accept the offer, and I'm very happy that they are academic partner for this program. So we have 6 programs lined up for you, and you will get that timetable soon. It's there available on the website, where there are going to be 6 programs on acute myocardial infarction and its complication, its management, and 6 programs on heart failure. I wish you all the best, and I'm sure the time that you're investing in today, that is your 1 hour, is going to be very useful in not only improving your knowledge, but which would lead to better patient management. Thanks, Team emcure. Thanks, all delegates, for joining. Thanks, API. And special thanks to Dr. Bang and Dr. Sunil THANVI. Over to you, team.
Now I request Dr. Vijay Bang sir to proceed for the your remarks, opening remarks. Thank you.
Good evening, everyone. We have this AMI program, a faculty program set up by emcure and API together. And I have the pleasure and honor of being here to say a few words in the beginning about how the STEMI care is taken in India. That is something we need to understand clearly, so that tomorrow when we have a AMI patient, acute MI patient, we look at him in such a way that we can expedite his care, STEMI care, in shortest possible time. And all the physicians and the cardiologists have to come together to understand this, how to impart this STEMI care program. What we have in India currently, I would like to share some slides with you and show some data on how much is the problem in India with the acute myocardial infarction. India, every year we see about approximately 3 million STEMI cases. Out of that, 10 to 30% die due to AMI. And only 53% get ambulance to get transferred to the hospital, either cath lab capable hospital or hospital where thrombolysis can be given, diagnosis can be made, or only ECG care hospital where, we have several tiers in India. So, and urban and the rural care, it has a lot of differences in terms of infrastructure and the availability of that for the diagnosis, thrombolysis care, and the PAMI care. So out of the 100 patient, 47 patient will travel by his own transport. And those who travel by their own transport, out of that, 1 in 300 will die. Because if they develop cardiac arrest, there is no way we can convert them to sinus rhythm. We don't have a DC conversion facility in the taxis. So where do we stand today in terms of, reaching the patient for PAMI? That should be a standard of care in anywhere in the world for acute myocardial infarction. It takes about 360 minutes, ranging from 123 minutes to 1317 minutes in India. And in Western country, it takes about 130 to 170 minutes. So how does it impact the country-wise? Because of the economic and socio-economic status of the country. The higher income group, higher income countries will reach their patient earlier than the middle and lower income countries. So it's a big challenge. There are two registries which have been presented and done, one after the other, the CREATE registry and the Kerala registry. And both these registries have registered large number of patients and shown that there is awareness increasing in India. The PAMI care is also increasing, and pharmacoinvasive care is also improving, meaning first you get a thrombolysis, and then you get transferred to a cath lab center where they will do angiography and do angioplasty if required. So this is we call a pharmacoinvasive care. In India, the kind of care that we have currently, STEMI care that we have, is pharmacoinvasive. So 95% of the patient receive thrombolysis. And we have something which is very important for thrombolysis, which is tenecteplase, a single bolus dose. In a very quick time, it is very effective if patient reaches in time. Most of our patients do not reach on time. And there are several challenges that we face. One is we have very few laboratories, cath lab laboratories, where angiography, angioplasty can be offered to the patient. And they are mainly located in urban areas. And rural areas, they are not available. We have poor infrastructure, road infrastructure, a lot of traffic. So it takes longer time for transportation. Then there we have a lack of insurance facilities. An outcome for the STEMI is very serious when you have a delay in STEMI care. So where are the problems? What are the choke points? One is the patient-related, logistic-related, healthcare-related choke points. What do we need to do to take care of? First, the patient must recognize the symptom that this is heart attack, a serious event in his life. If he doesn't seek a medical attention, his life is in danger. He might die. So education of the patient, social media education of the patient becomes very, very important today. And logistics have to improve so that patient is transported immediately. For that, we need a policy change, the investment in emergency care, infrastructure. The government must issue the legislation so that all this care should be imparted without any delay to the patient. Because here time is muscle. The more you delay, the patient will have more problem and will have more mortality. So low-cost ECG is very important, and transferring the ECG, the devices are available in 5,000, where we can transfer the ECG for diagnosis to a ICU care center or cath lab capable center or thrombolysis capable center. So all this, where the ischemic time goes away, is very important. We have to understand, we have to educate our people so that we can reach the patient for either door to needle time is limited or door to balloon time is even more limited. For that, single call must initiate the action at the cardiologist level, physician level, cath lab level, and the emergency service level. So that patient, if we have all these integrated in our network, in our system, and that happens only when there is a legislation. government takes the interest in this, then patient can reach in time and we can take care of it. The ultimately goal is each and every patient must receive the PAMI. That is where the results are the best. But pharmacoinvasive results are not bad. If you compare the pharmacoinvasive and the PAMI, the mortality is absolutely identical, 2%. So at least thrombolysis must be given to the patient, and best thrombolysis that I can see today is with a minimum of intracranial bleeding, other hemorrhages, and minimum problem, single bolus dose is tenecteplase. Very useful, very good molecule, but the cost is main concern because the affordability in our country is problem, insurance is problem. So there are 5 players in the patient himself, he must recognize, the family doctor or a general practitioner, he must recognize to transfer this patient immediately to the emergency care, through emergency care, either to primary PAMI care or cath lab capable center or non-PCI center where thrombolysis can be given immediately. So we have this spoke and hub pattern, which in the center is a cath lab capable, then thrombolysis, then ECG. That is how, that is if the from ECG to cath lab capable center, if patient is going to reach more than half an hour, then better to thrombolyze the patient. That is how we have only pharmacoinvasive even in urban areas. Because the patient that reaches late will have a poor prognosis if he doesn't receive thrombolysis on time. And we of course need a proper navigation facility on the Google map to find out where are our cath lab capable center, the thrombolysis capable center, ECG diagnosis center for STEMI care. So that each and every patient who has a problem of STEMI must receive, ultimate goal is primary PAMI, primary angioplasty. So these are the challenges that we are facing at the moment, and we have progressed in some way. We have created in 10 states, this module is available, including Gujarat, that this module is available where we have a system, spoke and hub pattern, where patient is informed and some care has been done on a technical basis. So they integrate the private and the government hospital in the care so that patient can be treated on time. And then there is an app, there is a web. So ultimate focus is what? Prevention, education, awareness about the recognition of gravity of urgency in reaching to the hospital, ECG facilities, soluble aspirin, pharmacoinvasive approach, that is thrombolysis, should be available in time. Everyone should be able to afford thrombolysis, which is safe and given quickly in single dose. And then, of course, a beta blocker, which is very helpful in acute MI in reducing the mortality and also reducing the salvaging the myocardium, reducing the infarct size. And post-MI secondary prophylaxis is very important. So this is how we are progressing in India. How does it impact? If suppose a patient doesn't receive thrombolysis on time, his mortality is higher as compared to the patient who receives thrombolysis on time. And if he, after thrombolysis, if the patient receives also the cath lab care, the angioplasty, what we call a post-MI facilitated angioplasty, then that patient and patient who receives PAMI directly within that golden hour, they both have 2% mortality, which is identical. But the MACE rate is little more in pharmacoinvasive arm, but not statistically significant. So definitely, if you have a education to the patient, if you have this spoke hub pattern created and network is activated for STEMI care, we can definitely improve the care across India. But a lot of work needs to be done. We have not reached yet the goal. At least First, we should reach the pharmacoinvasive goal well in time across India. So this is the message that we need to carry. So ultimately, in summary, I would like to say the all player in STEMI network have to work as one. Integration of all 5 players has to be there. The STEMI care has to be coordinated with logistics. And nighttime, it is particularly difficult coordination because number of staff is very low. And patient need to know symptoms. That is most important. Patient must recognize that he has emergency heart attack. He has acute myocardial infarction. He has to rush to the hospital, seek the medical attention, and go for a proper treatment. So that every STEMI must be treated by primary PCI. That should be a standard of goal. Otherwise, minimum is pharmacoinvasive PCI, not less than that. Thank you very much for your kind attention. Let me stop sharing. And with this, now I invite Dr. SUNIL THANVI to deliver his talk. Dr. SUNIL THANVI.
Thank you, Dr. Bang. It's an honor to be on the same stage with you. And I fully agree. The concerns that you have raised regarding STEMI care in India, a lot needs to be done, a lot needs to be understood, a lot needs to be regulated. And as you correctly put it, legislation is bound to play a major role in trying to streamline, the standard of care for STEMI for patients across the country. Unlike in West, where the authorities and the regulatory bodies are in sync with the medical authority, and they understand the gravity and importance of therapies. I guess, unfortunately, our country still lacks that maturity or that lack of understanding. Just hope that in the time to come, we can achieve that. So with that small preamble, I'll just start my talk for today, which is on thrombolysis in STEMI, when to and when not to. Next slide, Namdeep. Right. So in today's talk, I'll just take you through the when to and when not to, the contraindications, and as Dr. Bang very clearly put it, the concept of facilitated PCI or pharmacokinetic approach, when and how can be done. So when a patient of chest pain presents to us, or presents to you in the clinic or in your emergency room, you normally look at him clinically first, look at the various signs and symptoms the patient is having, and you put a working diagnosis of an acute coronary syndrome, depending on his the symptoms and the coexisting morbidities and the likelihood of angina, so on and so forth. Third thing that you come into is the ECG, where you look for ST elevation or ST depression or any deviation from baseline that could be seen in these patients. Mind you, many times, especially when the patient is having a circumflex occlusion, the ECG may actually look normal. And that is the time when as a matter of fact, all patients who come to the ER with a chest pain should have a right-sided ECG, and if possible, a posterior lead should be taken to rule out a posterior MI or a circumflex that is there. Following an ECG, biochemistry comes into play, wherein you look at the troponin levels, whether they are high, or whether they're low, or whether they're normal. Now, an ECG showing an ST elevation, the diagnosis is ST elevation MI. And ECG not showing ST elevation, but ST depression, T inversion, ST shifts, or maybe a normal or sort of a non-specific ECG, we cannot say that the patient is not having an MI, but we can definitely say the patient is probably not having an ST elevation MI. So standard troponin, the troponin is normal, and the patients, because there are ECG changes which are fresh, which are not there earlier, therefore the patient could be having unstable angina. And if the same patient, same ECG, the troponin is higher, then the patient is labeled as having a non-ST elevation MI. If we look at the pathology, basically it is about an occlusive thrombus that occludes the artery, which leads to ST elevation on ECG, and what we call the transmural infarct or a ST elevation MI. For non-ST elevation MI or unstable angina, the thrombus are less occlusive, made in the non-occlusive, and the lumen is occluded to 80 to 90%, having some flow, and therefore, although there is some damage with non-STEMI, the infarct is not transmural, it's probably just subendocardial. That is what the earlier terminology used to be for non-STEMI as a subendocardial MI. For STEMI, it used to be a transmural infarct. And for unstable angina, definitely the thrombus burden is pretty less, not leading to any sort of myocardial damage. Therefore, the troponins are normal. So the whole spectrum of ACS would be a STEMI, a non-STEMI, and unstable angina. STEMI is a major risk factor in ACS and has the highest rate of mortality, nearly 14 to 15%, even in today's world. If you look at the diagnosis of acute MI, there are 5 aspects. First is a clinical diagnosis, wherein you look at the angina type of pain, or what we call as an angina, probable angina, ischemic pain. Second is the ECG. Third is the biochemistry. Fourth, of course, is the echocardiography, because biochemistry takes time. If your ECG is non-specific and you're still pretty sure that the patient still could be having an acute MI, just put an echo probe if it is there in your clinic or in your ER. And if you see a wall motion abnormality which is new, which was not there earlier, and you're dead sure that the patient is having an infarct, then the patient needs to be intervened as early as possible. And the fifth, of course, if either the patient is too late or we are too late, then it could be a post-mortem pathology diagnosis wherein you could see an infarct of the heart. So these are the 5 ways how we can actually diagnose an acute MI, and that is what we should be doing. Next. So every year, an estimated of more than 7 million people are diagnosed with ACS worldwide. India being a diabetic capital, hypertension capital, cardiometabolic capital, we actually have higher number of younger patients coming to us, not only with acute MIs, but worse disease, worse outcomes, and worse prognosis. Patients with STEMI should receive coronary perfusion therapy with either primary PCI or thrombolysis. Primary PCI being the standard of care worldwide, having the best possible outcomes and the best possible prognosis in these patients. And of course, with thrombolysis, we can look at either a facilitated PCI or a pharmacologic approach, which I'll touch upon in my next few slides. Next. So as Dr. Bang very clearly put it, the time as a therapeutic target in acute MI is very, very important. The first star is golden, and that is the time when actually we should be targeting to intervene in these patients. And that is where the importance of education, awareness amongst patients come in. Next. So if you look at this graph, as you can see, the red is the critical time dependent period, the goal being myocardial salt. That is the time, the first couple of hours wherein we need to intervene. As you can see from that cartoon, that the animation, that as the time increases, the myocardial damage, the transmural infarct size keeps on increasing, and which usually is non-reversible. So if you're able to intervene in these patients in the first couple of hours, you're going to give him the minimum possible damage and the best possible outcome for his future. The yellow or the golden lines that you can see is actually time independent period, and where the goal is just an open infarcted artery, which can still be extended to 12 hours if the patient is still having ongoing chest pain, STs being there. Probably you can still go in and do a PCR or thrombolysis, but there when the goal would just to be have an open infarct artery, we will not be able to prevent the infarct progression in that case. Next. So time is very, very important, and as you can see, where are the delays? As Dr. Bang also very clearly put it, patient delay. That is where most of patients do not like to believe that they are having a heart attack. They would like to believe that they are having a gastric problem, they are having whatever, muscular pain, diaphoresis because of low sugar, high BP, but heart attack is something they don't like to believe that they are having. So that's the first step that we should be taking. We need to educate our public, educate our high-risk subgroups in general about the fact that if they're facing a scenario wherein there is a typical angina type of a pain with diaphoresis, even with giddiness or whatever, they could be having an ongoing infarct. In fact, diabetic patients may be having a silent event wherein they just could be having unexplained breathlessness, fatigability, just giddiness, inability to work, or unexplained fatigue. These are certain things that could still point toward an ongoing event. Second is when they call in for an emergency medical service. The second delay could be over there. Of course, especially in the state of Gujarat, we have a 108, which is very, very active. And therefore, the delays are minimum. But still, the patient needs to call them. The EMS comes in, they have a look at the patient, they take him to the nearest hospital. Hopefully, the patient is a PCI-capable center. The patient goes to the ER, gets an ECG done, clinical evaluation, ST elevation, goes in straight for a primary PCI, and the reperfusion is done. The goal for reperfusion for a primary PCI is less than 120 minutes, which means less than 2 hours from symptom onset. That is what the goal should be. So that is what is very important to minimize patient delays and EMS delays. If the patient reaches a non-PCI hospital, then of course there's again a time delay, because therein the patient will be in ER, they'll take an ECG, they will discuss about the options. The patient would still like to think about the financial considerations. They might delay about going for a PCI capable center. And that is where I believe that a thrombolytic strategy becomes more important, because rather than delaying time in taking a decision for reperfusion, it is better to thrombolize, let them decide, and then ship the patient once he's willing and ready for an intervention. So patient delay, system delay needs to be addressed very, very critically to reduce the total ischemic time to get the best possible outcomes in our patients. Next. Again, as I can see in this graph, that time is actually very, very important. What they say now is that if the patient reaches via ER, it is in the first 10 minutes. In fact, in the first 5 minutes, you're supposed to take an ECG and diagnose that the patient has an ST elevation MI. Having diagnosed, you either activate the code, get the cath lab, and wheel the patient straight away to the cath lab, or if you are in a PCI non-capable center where the PCI cannot be done or cath lab is not there, then in the next 5 minutes, the first bolus of a lytic should be given, and then the patient should be transferred to PCI capable center. Why? Because as I showed earlier, time is muscle, and it is very, very important to reperfuse the patient within the first hour. Benefit of lysing the patient would be, of course, that the patient, until he's waiting to reach the PCI capable center, get into the cath lab, get his artery open, the lighting would have started working, and definitely the patency of artery would be much better. The reperfusion would have started, and the patient would benefit out of it. Next. The European Society guidelines very clearly say that if you're looking at the important time targets in patients with acute MI, maximum time from first medical contact to ECG and diagnosis should be less than 10 minutes. Maximum expected delay from STEMI diagnosis to primary PCI, that is wire crossing, so that the artery opens up. To choose primary PCI strategy over lysis, if this target time cannot be met, consider like that is what they say is less than 120 minutes. So if the patient is not going to reach a PCI capable hospital and get his artery open in the next couple of hours, it is better to lyse than not to. But if he's in a PCI capable hospital, his artery should be opened within the next 120 minutes. That is what they need to say. Maximum time from STEMI diagnosis to wire crossing patients within the primary PCI hospital should be less than 60 minutes. So if the patient within my ER, diagnosed with an ST elevation MI, I take him up to the cath lab, his artery should be open within the next 60 minutes. That is the recommendation. Maximum time from STEMI diagnosis to wire crossing in transferred patient, we add another 30 minutes for transfer, and that should be less than 90 minutes. Maximum time of STEMI diagnosis to bolus or infusion start of lysis in patients unable to meet primary PCI target times should be less than 10 minutes. So this is very, very important. The time to diagnosis and the time to lysis should be as minimum as possible so that you can give the best possible benefits. And time delay from start of lysis to evaluation of its efficacy, success or failure, is 60 to 90 minutes. So you reevaluate the patient, look at the ECG, look at the clinical symptoms. If is the ST segment resolution of more than 50%, and if the patient's chest pain has gone down by 50% or more, then probably you know that lysis has worked, and the patient can wait for an hour or so, and then can be transferred to a PCI capable center. From start of lysis to transfer to angiography lab, if lysis is successful, that is, if the patient can wait, should be anywhere between 2 to 24 hours, depending, if it's interval MI, posterior MI, interval MI, how the lysis result is, and how the patient is behaving. And of course, the point is that if the lysis is not successful, the patient has to be immediately transferred to PCI capable hospital so that rescue PCI can be done. This is very, very important. These are the important timelines that you should understand, that as a cardiologist, for us, this is what we are fighting against day and night. And this is very important, not only to give the best possible result, but also so that the survival and the long-term results of these patients are best. Next. So if you look at the recommendations for repair strategy in STEMI, they say that a primary PCI study recommended over lysis within indicated time frame, that is a class 1A. However, if primary PCI cannot be performed timely after STEMI diagnosis, lytic therapy is recommended within 12 hours symptom onset in patients without contraindication. This is very, very important. If and only if you cannot do a primary PCI, for whatever reasons, patient should be lysed if there is no contraindication, even if the pain has been there for the last few hours, provided there is ongoing chest pain and provided there is ongoing ST elevation. Next. The guideline recommendation, as you can see very clearly, is that as soon as possible, treatment in STEMI patients to reduce mortality. For patient who is a candidate for reperfusion, if it's a PCI capable hospital, he is wheeled straight to the cath lab, an angio is done. You look at the culprit vessel, you talk to the relatives, and you proceed for a PCI immediately. This whole timeline is less than 16 minutes. Within 16 minutes, we are supposed to open up the artery so that the patient gets the maximum possible result. If the patient has been transferred from other hospital, the time delay cannot be more than 90 minutes, or max to max, they say, is 120 minutes. Beyond that, probably the benefit of doing a PCI, primary PCI for that matter, doesn't really hold well, and it would rather be better to go for a facilitated PCI or what you call as a pharmacokinetic approach in that group of patients. Next. So if the patient comes to non-PCI capable hospital, then there are two options. If the transfer time, that we call the DDO time, the door in and door out. The DDO time is less than 30 minutes, because in a lot of corporate hospitals, there's a lot of time that the management takes to show the patient out. A lot of paperwork going on. But if you can arrange for a DDO time to be less than 30 minutes, and if a cath lab is nearby, say another 10-20 minutes, probably in the next 30-40 minutes, the patient can reach a PCI capable center, then definitely transfer the patient for primary PCI is the way to go. However, if the DDO time is going to be higher, or if the PCI capable center is not near, then you have to administer lytic within 30 minutes of arrival and load with antiplatelets and shift the patient as soon as possible to a cath lab or a PCI capable center for that matter, so that the patient can be dealt with immediately. Next. So reported strategy in STEMI according to time from symptom onset would be 0, 3 hours, 12 hours. Up to 3 hours, it is primary PCI class 1A. Lysis also is 1A, only if PCI cannot be performed within 120 minutes from STEMI diagnosis. And if you look at the next few hours, 3 hours or 12 hours, then primary PCI still is 1A. Lysis again is 1A if PCI can perform within 20 minutes from STEMI diagnosis. So whatever it is, we are talking about patients having ongoing symptoms, ongoing ST elevation, and either of the two can be done depending on where the patient actually presents. In our country, even in my hospital, a lot of time it does happen that when the patient presents to you in the ER, you tell them that ST elevation in my patient needs to be wheeled to the cath lab. They will call up 5 other people. They'll call up 5 other doctors. They will take their own time deciding what they need to do, and they lose nearly 20 to 30 minutes in this whole process. So when I see a patient dilly-dallying, or when I feel the patient may not be financially, mentally, or emotionally prepared for this, then probably I do advise them that, okay, we'll go ahead with the lysis, and then meanwhile take your time to decide what needs to be done. But at least we need to do something. Cannot leave the patient just like that. So this is very important, that we should not be hung up upon an invasive strategy just because we're in a PCI capable center. Time is very, very important. Many times the cath labs are busy. There is a complex intervention going on. It's not going to be free within the next couple of hours. You can't give the patient in ER waiting for a primary PCI. It's better to lyse the patient than take the patient up to cath lab, so that at least the lytic starts working and the artery opens up because of that. Next. This is the change in recommendation that happened in 2017 when the concepts of were changing regarding the STEMI therapies. So when you look at the 2012 and 2017 guidelines, you can see the green is class 1, yellow is class 2A, red is of course class 3, and orange is class 2B. So radial access became the way to go, and regular stents over BMS was now there. Complete revascularization, which was actually contraindicated earlier, became a class 2A, and they said that if the patient is having a multivessel critical lesions, many patients come to you with intraoral MI and lesions in both circumflex and an RCA, and if the patient, especially if he's in cardiogenic shock, or if you feel that both that is equally important, they are co-dominant, then probably doing a complete revascularization at that point of time does help in the outcomes. Thrombus aspiration, the trials have not been really great, and therefore, although it's not contraindicated, but they say that probably we will not get those survival benefits by thrombus aspiration. But I, as a cardiologist, I don't know. Thrombus aspiration, IRBP, these are two things which we are, I'm at odds with the trials, because our clinical experience tells us that these two are the most wonderful tools. However, unfortunately, the trials may be not powered enough to show their efficacy. Anyways, Vivaridine fell out of favor. Enoxaparin from 2B, they became 2A. Early hospital discharge again improved. And oxygen, that was also important. Early they used to give oxygens, when the saturation was below 95, they would start oxygen. But now they said that we should avoid giving oxygen so that oxygen toxicity is avoided. And it's only when the SATs go below 90 that you should be actually giving oxygen. Tenecteplase became, of course, they were always there for lysis, and they still continued to be there as the favored lytic therapy in all patients. And of course, in patients more than 75 years, the dose would be half. So these are all recommendations that came in, and it is very important for us to understand that the concepts are emerging, but lysis is always there, especially for our patients. Next. So they also said that a pre-hospital setting lysis would make a lot of sense, especially in areas which are far-fetched. In a remote setting, what would be the best therapy? So you have an EMS. I'm talking about an ideal scenario. You have an EMS reaches over there. They do an ECG. They transmit the ECG to the hub. The doctor sitting over there, he recognizes an estimation MI. They quickly look for the contraindications. Nothing. You lies. Take the patient up and send him straight away to the PCI capable center, where they can undergo, I'm not telling you something out of science fiction. My own brother-in-law was in Canada, and he was working in a store. He fell down from intraoral MI. He collapsed, and the EMS was called in. They reached there, I think, in less than 10 minutes or so, did an ECG, lysed him on the spot, took him up to the hospital straight away. Until his family reached the hospital, he was in the cath lab, and the PCI was about to be completed. So I think that is what we are looking at. That could be a utopian way for our patients, an ideal way to treat them. And of course, fibrin-specific agents should be used. Tenecteplase, alteplase, or retiplase is recommended. And patients more than 75, half dose is recommended. Antiplatelet therapy with fibrinolysis, oral aspiration should be given. Clop is indicated in addition to aspirin, though now we have some data for ticagrelor. However, prasugrel should be avoided as there is no data to the fact right now. Next. So what are the indications for lysis in STEMI? As I said earlier, in the absence of contraindications, lytic therapy should be administered to STEMI patients with symptom onset within the prior 12 hours and SC elevation greater than 0.1 millivolt in at least 2 contiguous precaudal leads or at least 2 adjacent limb leads. This is level of evidence A. Second indication is same symptom onset within the prior 12 hours and new or presumably new LVBB. That is again an indication where you can lyse the patient, provided that the patient is either far away from a primary PCI capable center or cannot be offered a primary PCI for whatever reasons. Class 2A would be a symptom onset within the prior 12 hours, ECG considered with a true post-through MI. And Of course, these are all in the absence of contraindication. That is very minor. Before you administer lytic, you have to go through a checklist of contraindications to be very sure that the patient doesn't bleed post-lysis, because otherwise you lose whatever you're going to gain. And the second class 2A indication is symptoms of STEMI beginning within prior 20 to 24 hours who have continuing ischemic symptoms with ST elevation greater than 0.1 millivolt in at least 2 contiguous precaudal, at least 2 adjacent limb leads. So even if the patient is more than 12 hours old, MI, but if he's continuing to having pain and ST elevations are still there, the patient can still be lysed to give him the possible benefit. Next. Class 3, which means we should not do, is lytic therapy should not be administered to asymptomatic patients whose initial symptoms of STEMI began more than 24 hours earlier. Mind you, if they are still symptomatic, if the ST elevation is still there, probably we can think of a reperfusion with lysis at that point of time. Second contraindication would be should not be administered to patients whose 12 ECG shows ST segment depression, except if a true posterior MI is suspected. And the best way to look at posterior MI is look at leads V2 to V3 and just flip the ECG. You flip the ECG and you will see the ST elevations in V2 to V3, and that is the sine qua non of a posterior MI. So if there's a posterior MI, you can still go ahead and lyse him. Otherwise, any ST segment depression never lies. Next. So that is where the concept of ST elevation, non-ST elevation came in. Earlier it used to be transfemoral infarct and subapical infarct, but that was a pathological diagnosis. This is actually a clinical diagnosis, a therapeutic diagnosis, and therefore it is important to understand this. So the international guidelines recommendation for lytic therapies, the American College of Cardiology, class A, when there is a more than 120-minute delay from first medical contact to primary PCI and the ischemic symptoms are less than 12 hours old. European Society guidelines, within 12 hours of symptom onset in patients without complications if primary PCI cannot be performed by an experienced team within 120 minutes of first medical contact. And Indian guidelines recommended when transfer time to PCI more than 30 minutes or door to balloon time in PCI capable center is more than 90 minutes. These are two conditions where still you may need to lyse the patients rather than go for a primary PCI. And tenecteplase single IV bolus recommended higher than with 1A recommendation than alteplase, which is 1B, and alteplase, which is 1C. So even as similar to what as Dr. Bang said, tenecteplase is, I think, the way to go, and that is the best possible therapeutic option that we have at this point of time. Next slide. As I said, and as Dr. Bang also put it very elegantly, in India, lytic therapy is still very relevant. Late arrival patients at PCI capable hospital is a real-time problem. Late initiation of reperfusion treatment, it's not only the patient but also the system delay, the staff delays, the patient taking time to decide, then the store in the middle of night. You have a lot of logistic issues coming in. Less than 10% of STEMI patients are getting PCR treatment on time, as the Kerala history showed us, and 59% of patients are given lytics as primary reperfusion therapy, even as of this date. So it is not as if lysis cannot be done, should not be done, but primary PCI is the way to go. If we cannot do it in time, better to lyse, send the patient for PCI as a facilitated or a pharmacokinetic approach. Next. Next slide. Yeah. So what does it do? It basically dissolves the dangerous intravascular clots to prevent ischemic damage by improving blood flow. Benefits of a pharmacoinvasive strategy are enhanced when it can be administered early, typically low risk presentation, absence of cardiogenic shock, and patient has no contraindication of fibrinolysis. In circumstances when PCR delays are expected to be significant, a lytic-based pharmacokinetic approach may be an attractive therapeutic option, as we will see shortly. Next. So basically, two types of lytics. One is fibrin-specific agent, and one are non-specific agents. Lytic, which are specific, are alteplase, reteplase, tenecteplase, and the good old streptokinase, urokinase, actually non-specific agents. And what, of course, we need to choose are fibrin-specific, and of them, tenecteplase is the most preferred agent. Next. So if you compare amongst all these, as you can see, that there's direct plasma activation by the alteplase, reteplase, and tenecteplase. They have no allergic reactions, And if you look at fibrin specificity is maximum for tender place, and the depletion of systemic fibrins is minimal, and patency at 90 minutes, STEMI grade 3 flow is maximal, and active depleted clot is maximal, and therefore, and of course, resistance to PI1 is there. So the point is that giving a therapy which has all the pluses and minimum minuses should be chosen, and that is where tender place comes into play. Next slide. Next. So difference between these three is that the dose schedule, as you can see, it's a single bolus, and it is given very quickly over 5 to 10 seconds, and you can easily achievable timelines. The dose adjustment is weight based, as you can do that. A lot of fibrin specificity, and the regional antigenicity as such, immediate flow percentage is maximum. So I think of these three, if we have to choose, I think tender place is the therapy of choice or the drug of choice that should be chosen over the other fibrin specific agents. Next. So this is from the NICE guidelines. They have put it very elegantly. In summary, given the evidence on clinical effectiveness, it can be concluded that in the hospital setting, in terms of mortality, standard altiplase is as effective as streptokinase, which means it is so-so. Retiplase is at least as effective as streptokinase, which again it means it is so-so, and tenteplase is as effective as accelerated altiplase. So which means that it is much more superior to streptokinase. If accelerated altiplase is believed to be superior to streptokinase, then indirectly tenteplase would also be considered superior to streptokinase. Furthermore, if retiplase is considered equivalent to accelerated altiplase, then this indirectly implies that retiplase is as effective as tenteplase. So what they mean to say is that tenteplase, retiplase, and altiplase in descending order should be the choice of agents for you. Next. The most preferred, of course, is tenteplase, and second would be TPA accelerated dosing. Patient more than 75 years, consider using half dose to mitigate the bleeding risk. Next. IV thrombolysis is widely applicable. We know that can be given even in remote places, and the molecules are available everywhere. In prior trials have been shown to unequivocally reduce mortality when given within 8 to 12 hours of symptoms. Earlier, the better. Early administration of newer fibrin specific lytis is at least as effective as primary PCI and can avoid infarction and dramatically reduce mortality when given during the first 1 to 2 hours of onset. Next. As Dr. Bang very clearly put it, that immediate thrombolysis is now recommended as an alternative to primary PCI in whom door to balloon time more than 90 minutes is expected. Next. Utility, however, is limited by the risk of bleeding in some subgroups, suboptimal rates of reperfusion, particularly in the presence of older thrombi, and a significant rate of reocclusion with detrimental impact upon mortality, but this is more so with the fibrin non-specific agents. Next. How best to combine both strategies? One is what we call as the facilitate or the immediate PCI. That is post-lysis, send the patient to a cath lab, and they do a PCI within the first couple of hours, or the first 3 hours, that is what they define as. And what the pharmacokinetic approach, where the radic therapy is followed by transfer to cath lab, and the PCI is performed within 3 to 24 hours, so that you give time for the radic therapy to have worked, to its bleeding effects to have reduced, and the patient gets the best possible benefits. Strategy of performing stenting hours after IV fibrosis is applicable to the entire population. The acute MI could represent a good alternative for the still high proportion of victims of this condition for whom PPCA is not available or requires an excess delay, which is true in our country, where most of the population are living in smaller towns, villages, remote areas, and even in cities where during office hours, a lot of congestion cannot reach a primary PCI capable hospital in time. Next. So factors favoring lysis-based pharmacological strategy. When you have an anticipated PCI-related delay of more than 60 minutes, non-PCI capable hospital or overtaxed health system wherein it is a constantly busy lab, diagnosis likely from acute occlusion, that is multiple CAD, or where the patient has a history of the segmental volume abnormality, low risk STEMI score, present 5 absence of cardiogenic shock. Therein, you can still go for lysis patient having early onset of symptoms, no absolute contraindication of lysis. These are all factors which favor a lytic-based pharmacokinetic therapy. Now, what it has two components. One, of course, is pharmacoinvasive. One is pharmacotherapy, and second is invasive therapy. The pharmacotherapy consists of giving a fibrin-specific agent, where the tenedipress is preferred. If PCI is performed, unfractionated enoxaparin is preferred until time of revascularization. Otherwise, if you're not going for PCI, then enoxaparin should be given until discharge or up to 8 days. Aspirin loading 325 milligram and then 81 milligram daily should be given. Clopi, less than 75 years, loading dose should be 300. More than 75 years, loading should be 75 milligram only. With lysis, avoid GP2B3 inhibitors. Secondary prevention, high intensity statins and beta blockers and so forth should be done. Now it is added with the invasive therapy, wherein you can do immediate rescue PCI in patients where the lytic therapy has failed, as in ST7 resolution is less than 50%. Patient still has ongoing chest pain, the chest pain index has not gone down, or the patient is sinking. You take the patient to cath lab immediately, and hemodynamic electric instability or ECG markers of failed perfusion, and the patient is taken to the cath lab and immediately undergoes a PCI. That is what we call as a rescue or immediate PCI. A routine early angiography in PCI is what we call as, with the first 3 hours as the facilitated PCI, ideally should take place between 2 to 24 hours, that is pharmacokinetic, particularly in patients whom COVID-19 is effectively ruled out. That is something which we now do very routinely. In COVID patients, which has not become a norm, angiography can occur after convalescence from active infection. Now, during COVID infection, this was a very big problem, because patients would not be reaching hospitals. Having reached hospitals, there were a lot of system delays and a lot of issues, with because not all hospitals will be having 2 or 3 cath labs wherein you can just keep one cath lab for COVID patients. So therein, lytic therapy was still the way to go, not only in India, but across Europe and across US too, where they could not have a dedicated cath lab for COVID patients. They would go for a lysis and then send the patient for pharmacokinetic therapy. Next. Now, lysis without routine transport for PCI. Now, this approach utilizes full dose lytics and reserves arterial angiography in PCI only if there's clinical evidence of primary failure of lysis. This could also be a way to go, especially in patients, in whom financial issues are there, remote areas, places where primary PCI capable centers are very far off. Then you can still try to give the patients and see how the lysis works. Primary failure lysis is usually assessed clinically by persistent or worsening chest pain, hemodynamic or electrical instability, or ECG markers of failed perfusion 60 to 90 minutes after administration of a lytic. And currently, rescue PCI is still utilized in the context of pharmacy strategy when indicated clinically. So if the lytic doesn't work, the patient has to be shifted no matter what and has to undergo a PCI for that matter. Next. A new treatment paradigm, as I was discussing about the pre-hospital lytic therapy, is a new treatment paradigm that can dramatically change patient outcomes, especially in countries like India, wherein the transfer times are always very high and there are patient delays and system delays. This could be a very good option. It is safe, reasonable when administered by skilled and first responders. That is the only catch. Our 108s have to be, staffed by people who are skilled, can take proper ECGs, and if possible, can recognize the gravity of situation and have facilities to transmit the ECG as fast as possible. Alteplase or tenteplase are commonly used lytic agents in pre-hospital settings, can be given as bolus and patients shifted immediately. To ensure standard of hospital lytic therapy, appropriate protocols with checklist, interpretation, transmission to the ECG, advanced cardiac support training, and uninterrupted availability of medical direction is mandatory. You cannot leave an EMS, send them to do a lytic, and just leave the patient on Ram Bharosa. You have to be there constantly with the team to guide them, to direct them, and to see that the patient doesn't suffer. Next. So what are the contraindications for lysis? Absolute contraindications: history of previous intracranial hemorrhage or stroke of unknown origin at any point of time, ischemic stroke in the preceding 6 months, central nervous system damage or neoplasms or AV malformations, recent major trauma, surgery, head injury within the preceding month, GI bleed within the past month, known bleeding disorder, of course not menses, but any bleeding disorder that the patient could be having has to be ruled out. Aortic dissections, the big no-no, you cannot lyse these patients. And non-compressible punctures in the past 24 hours, for example, post-liver biopsy, lumbar punctures, having put in ICD, whatever, where they're bleeding, where you cannot compress those punctures, don't lyse. Related contraindications would be TIA in the preceding 6 months, patients on oral anticoagulant therapy, pregnancy or within 1 week, postpartum, refractory hypertension, systolic BP more than 180, diastolic more than 110, don't lyse, advanced liver disease, infective endocarditis, active peptic ulcer, prolonged or traumatic resuscitation. These are all areas where you should avoid lysis. Next. So last couple of slides, clinical pearls. If the decision is made for lytic therapy, the lytic agent should be administered ideally within 10 minutes, if not at least 30 minutes of first medical contact. The European guidelines suggest a goal of 10 minutes for standard lytic therapy. Greatest benefit of lytic therapy is seen in high-risk patients when the lytic therapy is given within 2 hours of symptom onset. Adjunct use of clopidogrel preferred over other P2 inhibitors in patients receiving lytic therapy for acute MI. If patients undergo subsequent PCI after lytic therapy, patients can be switched from clopid to either TICA or prasugrel 48 hours after lytic therapy, so that the bleeding issues are not problematic to these patients. And next slide. And if you look at the anticoagulation therapy beyond 48 hours, the American guidelines clearly say that enoxaparin is better as compared to unfractioned heparin, unless the patient undergoes PCI. Next. So to summarize, delivery of timely and appropriate reproductive therapy remains the cornerstone of STEMI care, whether it is primary PCI, thrombolysis, facilitated PCI, or a pharmacokinetic approach. It has to be timely and appropriately done. Timely PCI is not always feasible in routine Indian clinical settings. Therefore, the whole concept of pharmacokinetic approach to our patients. Lytic therapy is a crucial tool in STEMI management. Lytic therapy is recommended in primary PCI, cannot be performed within 120 minutes from STEMI diagnosis. Pre-hospital lysis can be considered as a complementary part of any reproductive strategy in management of STEMI, which requires the coordinated efforts of an entire interprofessional team. Patients requiring lytic therapy can achieve the best possible outcomes with fewer adverse events if we have a good checklist and we go through very thoroughly. Tenecteplase is the most fibrin-specific single bolus lytic agent and best suitable for pre-hospital lysis or early thrombolysis. I thank you for your kind attention, and I hope that I have made the points clear and I've helped in some way to make you understand the importance and the relevance of lysis even in today's world. Thank you again.
Thank you, Sunil. Very nice talk. And you thoroughly covered entire aspect of the STEMI care. And we have to deliver this message that we have to educate masses. And the responsibility lies with physicians and cardiologists. You educate the masses that the recognition, immediate medical attention, not to think of anything, not to make their own diagnosis. Don't involve neighbors in making a diagnosis. Moment you have the chest pain, must attend to close by casualty, need not bother about going to the physician or going to if you have a chest pain which is significant, go to a nearby casualty, nursing home casualty, or wherever you can go to a very important thing is go to the casualty where ECG is taken, diagnosis is made. If the cath lab capable center is far away, going to take more than half an hour, thrombolysis can be given. If patient can afford single dose, will be better rather than giving a different type. If but patient cannot afford, we can use other types of thrombolytic agents which are available locally. So, but if nothing is given, we have already explained, if you don't give thrombolysis, the mortality and the damage, the morbidity is very, very high. So you have to give something, either thrombolysis, pharmacoinvasive, or facilitated PCI, PAMI. These are the few things you have to do in all STEMI care. But most important is patient education, Then education in remote areas, particularly in our rural areas, in remote areas of India where ECG facility may not be there. There are centers, there are small towns in remote areas where ECG facility is not there. But these days there are gadgets available in 4,000, 5,000, and there are NGOs who are ready to supply these to various clinics, where just you put 2 fingers and you can get the 12-lead ECG, which can be sent through the mobile to a nearby physician or a cardiologist who can read whether there is a heart attack or not, there is acute MI or not, ST elevation acute MI or not, and he can guide them to come to at least thrombolytic capable center. If PCI, if possible, primary PCI center. If not possible, at least thrombolysis capable center. And aspirin can be given to each and every patient, soluble aspirin, if there is any time delay. Because time is muscle. Moment you delay, the lot of myocardium gets dead. So this is message that we have to educate people. We have to propose government to issue a legislation in STEM care. I'm sure some states do have some legislation. I think Gujarat has some legislation in this respect. I'm not very sure you will be able to guide that, tell that surely. But I heard that there is some legislation in Gujarat. So we need to have some activity. We need to propose government that STEMI care has to improve. Not only that, each and every state must initiate a registry for STEMI, so that we have a data how many STEMI are actually taking place in India and what kind of care they get in various areas of India, and where we need to improve our care, in which part of India we need to improve our care. So overall care for all STEMI patients, if not primary PCI, at least should get pharmacoinvasive, minimum. This is our message today to all. And of course, question answers we have to take, and that the technical team will tell us. Dr. Dabhade will tell us whether there are any questions or not. We both can answer.
Yeah, so there are a couple of questions in the dedicated link for the audience we have created. So I would like to share few of the questions. I mean, I would like to ask to the panel. The first question is asked by Dr. Nagamoni from AP, Ongel University. He's asking about the dose of low molecular weight heparin for 100 kg male in case of this episode of MI. He's somewhere asking about the low molecular weight heparin. The question is about. Sir.
Yeah, so I think the dose is pretty clear. It's like 0.6 to 0.8 mg per kg. That is what is normally given to these patients. And the catch point is what normally should be done. You know, you should give what you're comfortable with. If you feel you're more comfortable with giving infection heparin, stick to that. If you're more comfortable giving LMWH, be with it. The recommendation definitely is for both the first 24 hours, beyond 24 hours, especially if the patient is not undergoing PCI, and if the patient is going for medical management and to be discharged, then enoxaparin, the data supports the use of enoxaparin in routine doses. There's nothing specific, no new dose for that. For PCI, of course, there are specific doses, but for patients who are on medical management, you may go to the routine doses, not a problem.
Right, sir. So I can see most of the questions been already answered during, the remarks by Dr. Bansal.
Here is an answer from an Alexa Answers contributor that I translated. Please.
Yeah. So the one question which I think been not covered during the talk, and this is about the usage of tenecteplase in patients with the pulmonary thromboembolism. So I agree that question is not directly linked with the today's topic, but audience is interested to know how this tenecteplase can be useful in pulmonary embolism. So if quickly you could answer for that, sir.
Dr. Bang, would you answer or should I do that?
See, pulmonary embolism depend upon management of pulmonary embolism depends upon the severity of pulmonary embolism. If it is very large, a CT scan shows it's very high amount of, then lysis intrathrombic will work. You have to go by catheter, put the catheter in the thrombus and give a lytic therapy in a titrated doses, which can be given, or else we can also, in case there is a problem of finding a lysis at that time, there are some times when there is lysis is not in enough quantity in many labs. So at that time, you can use low molecular weight heparin, or you can start patient on heparin, as Sunil said, either heparin or low molecular weight heparin. Anything can be started. Even NOAC are known to be very helpful, but it depends on what grade of pulmonary embolism. If pulmonary embolism is so severe that patient is very serious, is intubated, then only way that can help is going to take a catheter inside, do a mechanical lysis, or use some technology like thrombectomy devices, or penumbra devices also available these days, which has a typical facility of going inside peripheral penumbra is available in India. We can go inside the thrombus and lyse it completely mechanically using the console of the penumbra. So it depends on what stage of, if it is just a thrombus, not much, or microemboli leading to pulmonary hypertension, DVT, then and patient is mobile and there is no much symptom, then we can perhaps manage even with the NOAC for that matter.
Well, noted, sir. So sir, again, I can see in the chat box, many questions are all about the usage of tenecteplase and the usage by the physicians for this tenecteplase in routine practice and all. But every, I can just confirm that all the questions been already answered during your talk and by Dr. Sunil, sir. So, sir, with your permission, I would like to go for the conclusion of this event. Should I, sir?
Yeah, I have one slide to be shown.
Okay, yes. Please.
For the benefit of our participants who are there on board at the moment, but I'm trying to see that where that slide is. So let us see if I find the slide. I will definitely like to show that slide.
Sure.
And sorry, unable to find the slide. Basically, that slide had very well explained about all these aspects of what dose of low molecular weight heparin according to the weight of the patient can be given. That is one. Second, when to use what kind of treatment in pulmonary embolism. Briefly, whatever I said, it is the same. There's no difference in, I and Sunil have answered both this question, and there's no difference in that. It's very clear. So if any question we would like to answer.
No more questions, sir. I can see now. All the questions unanswered we have taken.
So shall I give closing remarks?
Yeah, of course, sir. So I just request you for your closure remarks, and we can just conclude the session.
So, see, if you look at the journey or life after a STEMI, if a patient has a STEMI and if he receives a PAMI, he receives pharmacoinvasive approach, he receives thrombolysis, or he receives nothing. If he has a major infarct like LED occlusion causing anterior wall MI, causing a lot of muscle drain, it can lead to aneurysm. And 65% of all sudden death is due to STEMI. 65%. Second most important thing, if you see heart failure, the most important cause of heart failure is STEMI. So these are the heart failure, cardiac arrest. These are the maximum causes of mortality across the world. That's why we say that coronary artery disease is #1 killer of the human race. The main problem is in public level, the recognition of the symptom. That is where major delay is there. Most of the time, the family takes a lot of time to take a decision to take him to the hospital because mentally they are not prepared to take him to the hospital, which is understandable. But ultimately, unless we educate as a doctors, we educate the community, this is not going to change. It is responsibility of each and everyone, each and every doctor, educate the families. The heart, if you have a heart blockages or if you have a heart attack, you are heading for a serious event. So if you don't take care of you, it will take a toll either due to morbidity, heart failure, or due to mortality. And whole family takes the toll. The simple therapy which is available, the diagnosis, and within 120 minutes, thrombolysis, if possible, first, of course, PAMI. If PAMI is not possible, thrombolysis, or some way we educate people to understand this. This is a very important aspect, and we all are responsible. If people don't understand, doctors are responsible. Healthcare system is responsible. Government is responsible. So and this should be now part of the curriculum, school curriculum, recognizing heart attack. People should know right from the school time how to recognize heart attack and where to seek a medical attention. How serious these events are. I hope some government people listening to what I'm saying, and this should go as a message to everyone. That is how we can impart a maximum benefit to maximum community and reduce the risk factors. The heart disease is caused by obesity, hypertension, diabetes. What is obesity due to? Lack of physical exercise, sedentary lifestyle, and improper food habit. Junk food, definitely you are heading for obesity. Once you have increased BMI, then you develop the diabetes, blood pressure, and then there is a cardiometabolic syndrome and high risk of CVD, cardiovascular disease, mainly heart attack and stroke, two important organs. And once you have a cardiometabolic syndrome, kidney is next to get affected, and that will lead to renal cardiometabolic syndrome. That is even serious event. So this cycle can be reversed. Even if you have put on weight, you develop a cardiometabolic syndrome. This can be reversed if you start healthy diet, and regular exercise, it can be reversed. Your diabetes can disappear, your blood pressure can disappear, and you can become normal, healthy yourself. But you have to believe and remain committed in achieving this. This is the message for today.
So nice message, sir. I think the awareness in terms of the patients for the healthy lifestyle, and for all the audience in the form of consulting physicians who are with us today in the audience, we'll take this message home, and definitely this first session of acute myocardial infarction can be considered the successful once the message will be taken seriously, and we hope for that.
And it reaches the community level.
Yeah, at till the community level, of course. And just to share with you and with all the audience, emcure already taking few of the steps in the form of hub and spoke model we are running across India, just like the STEMI Tamil Nadu model, and we are also having the regular such courses, and also one dedicated course on heart attack management certification we have done just before to this with Dr. Professor G.S. Wanda. So we are also aware and sensitive about spreading the message. So yeah, so with that, sir, I'm really thankful to you and Dr. Sunil Thanvi, sir, for the nice presentation and the deliberation today. And with that note, I would like to once again say thank you to all the audience here today. And let's meet with the next topic in this series in the next month. So we are having the monthly series of this particular AMI workshop. Thank you, sir. Thank you. Very good evening and good time ahead. Good night. Thank you. Thank you.
Good night, sir.